Well, thank you for that very warm welcome, and indeed for the very warm welcome to the cluster here. It's been absolutely wonderful to be here for a couple of weeks, and now that I know what it's like here, you're going to have trouble keeping me away. I'm going to talk to you today about a new book that will be coming out on May 27th. And it will be open access from the publisher, so I'll make sure that we send out an email or something like that so you all know where to get access to it. The book is Getting Better, the Politics and Policy, Policy and Politics, I can never remember which order it's supposed to go in, of reducing health inequalities. So I am turning down a really precious opportunity to get feedback from you all on new work in order to present work that's already done today. And there's a reason for that. The reason is that I think we too rarely present public-facing work that we do to audiences of our peers. And this is a public-facing book. This is the second public-facing book that this team of authors, Claire Bambara, Kat Smith, and I have produced. The first was The Unequal Pandemic, which came out in 2021. And I think that scholars of inequality should do public-facing work. I think we should do more of it if we can. But I think it's important to talk about how that differs from some of the other work that we do and how to make it more comfortable for us to do that. And I'm delighted to know that you also have the services of Andreas, who is someone who does public-facing work all the time. So this is a scholarly approach to it. So what I'm going to do today is I'm going to introduce the book, just tell you a little bit about what we do in the book, and spend a little bit of time talking about the methods that we use to create this book, which are quite different from the methods that one would ordinarily use in producing a piece of research that's geared toward an audience of our peers. I'm going to walk through one of the case studies from the book, and then I'm going to spend a little bit of time talking about how we made the book public-facing and sort of what that meant for us. So to begin with, I always have to start a talk by defining health inequalities. Health inequalities are typically defined in the international literature as unfair differences in health outcomes, things like mortality, health status, well-being, not, in fact, as differences in access to healthcare or use of healthcare. And there are some countries where it's much more common to talk about health inequalities as inequalities in healthcare, and I think Germany, until very recently, was one of those countries, so I want to be really clear what I'm talking about. These inequalities can occur across multiple social dimensions, so they could be across race or ethnicity, across socioeconomic position or class, across age, gender, disability status. And they're unfair. These inequalities are unfair because they're due to the organization of society and the economy, not due to unconstrained individual choices. I think we all have the intuition that if people were choosing freely and making decisions that affect their health, then maybe differences across social groups wouldn't matter so much. But these are unfair because they're socially structured. And finally, healthcare contributes a relatively small amount, somewhere between 10 and 30% of variation in health outcomes is due to access to healthcare, use of healthcare, quality of healthcare. And this is a sort of difficult quantity to estimate precisely, and there's a lot of disagreement in the literature about it. But the main point is just that there's a lot of other stuff that goes into people's health. So we shouldn't think about it only as about healthcare. Okay, so given that, why did we write this book? The first reason is that my co-author Claire Bambara and I have been in a fight for several years where she says the glass is half full. New Labor really did manage to make some progress on health inequalities in the 2000s. And I say the glass is half empty. They really should have been able to do much more. And Claire says back to me, Julie, you can't say that. right? Politically, you can't say that it's impossible to fix health inequalities. And Claire finally convinced me that the way that we tend to talk about health inequalities, and particularly the politics around health inequalities and policy, is really negative. As academic researchers, we tend to talk about how hard the problem of health inequalities is to solve. It's often characterized as a wicked problem, along with things like global climate change. Governments often fail even when they try to reduce health inequalities. This is a big part of what regimes of inequality was about. The evidence base, people talk about the evidence base for policymaking being relatively weak. And all of these sort of negative ways of talking about health inequalities, I think can, in places where policymakers are actually paying attention to academic researchers, which is not everywhere, but is true in some places, this can really contribute to political and policy paralysis. At the same time, there really are reasons for being optimistic. Claire has finally convinced me. It is certainly the case that the evidence base for doing things that could potentially reduce health inequalities is much broader than just the randomized controlled trials that some health economists would like to see us do and would say are sort of the only viable form of evidence. We argue that there are actually lots of forms of evidence that can, taken together, give us a pretty strong indication of what kinds of policies are likely to work to reduce health inequalities. Furthermore, governments very often act without evidence, right? My laugh line is, you want to hear a joke? Evidence-based policymaking. Right? Like, everybody knows that governments don't always use evidence when they're making policy, and some governments use less than others. Certainly in the case of health inequalities, governments are very often taking a leap into the dark. So why not, right? And the final reason for optimism, and the reason that we wrote this book, is that governments have, in fact, managed to reduce health inequalities, at least temporarily, despite the fact that this is something that's really hard to do. It's a massive challenge, and we don't know everything about how to do it. So we wanted to get some of that information out there. How have governments done this? So in the book, we present 4 real-world examples of governments doing things that led to fairly substantially reducing health inequalities. And we tried to pick cases that were as different as possible. Different time periods, different places, different levels of economic development, different healthcare systems, etc. We ended with these 4 cases: the US during the Great Society, which I'm going to talk about today, Brazil during the period following democratization in the mid-1980s, Germany after reunification, and the UK during New Labour's health inequality strategy, which I already mentioned. And for each of these case studies, we talk about the waxing periods, the periods of growing political awareness and policy action aimed at reducing socioeconomic inequality generally, and in some cases, health inequality specifically. And we also talk about waning periods. What happens when it all falls apart, which unfortunately it does in all 4 of these cases. So this is not a sunshine and roses kind of book, although we are attempting to be positive. There are very real constraints that come back to bite us. All right, so what do? What are the methods that we use to build these narrative case studies, which we hope will be readable and compelling and enough storytelling to keep a lay audience interested in what we have to say? So essentially what we're doing here is a very, very thorough literature review. But it's a literature review that is so thorough that we have a great deal of confidence that what we are saying doesn't need to be extensively cited, doesn't need to be hedged, doesn't need to be presented in academic jargon. It's so thorough that we're pretty convinced that we can speak from our hearts and say, this is what's happening in the most compelling way possible. So I want to go into a little bit of depth with this sort of literature review method to just show you exactly what it means. So as people who are steeped in the literature on social determinants of health, we reached back. The first thing we did to build these narratives of how governments did what they did is we used our theories to generate a list of the things that we know have an impact on health during the pre-reform period. So before the reforms start, what does the distribution of the social, economic, and political determinants of health look like? Because we think this should tell us what the distribution of health looks like in the pre-reform period. Okay, so we use our theories to generate sort of a set of places to look. And then we use government statistics, a lot of primary sources, and the secondary literature to document as carefully as we can what the distribution of the determinants of health and of health outcomes looks like across the social divides that we think are particularly salient in a society. So in the US, we are looking at essentially race and class. In Germany, we're really looking at sort of East versus West. In Germany, we also look a little bit at age and gender. So we're very carefully sort of documenting what the pre-reform period looks like. And then we go to the legislation and to the primary and secondary literature about these periods to say, okay, what are the policies? What is every policy that was enacted during this period of time that was either enacted or expanded or reformed in a way that aimed at affecting the distribution of the social determinants of health? So this is sort of our pre-reform period. Then we tackle the reform. So we've already told you what happened, sort of what were the policies. Then we go back again and we look at those government statistics, the sort of work that was done at the time in policy evaluation, journalism around this period, and to the secondary literature to describe what the post-reform distribution of health outcomes looks like. Okay, pretty basic, pre-post, right? We're just being very, very thorough about it. And wherever possible, we're going to the secondary literature, typically to health economists, labor economists, or epidemiologists, to see if there's any research that shows that a changed distribution of one of the social determinants of health, so let's say the quality of housing that people have access to, or education, or changes in the regulation of the labor market, to see if there's a causally identified link between the thing that the policy changed and the health outcomes. In many cases, there isn't. So for example, there's very little policy evaluation literature in Brazil that actually gives us clean causal identification. The US is the case where there's probably the most, and the UK the next most. So where it's not possible to find this secondary analysis that shows sort of clear causal inference in the way that we as social scientists would like to see it, we go back to our theories and we go back to the secondary literature that doesn't show a causal influence, but that allows us to estimate the likely effects of changing the policy, which changes the distribution of the social determinants of health, which then changes the distribution of health. So for example, one of the ways that we can do this is, there's no contemporaneous evaluation of the Head Start program in the US, which is an early childhood education program, and its impacts on on health at the time. But we have some literature from later periods, like in the 1970s and 1980s, that does show a causal impact. And so we can sort of make inferences about what we think the causal impact is likely to be. Okay, so this is the waxing narrative. And this is kind of the most important part. The waning narrative we're kind of a little bit less concerned about. It's not our main focus, so we're not sort of as worried about identifying which impacts are sort of causal in our social scientific terms. But again, so we find ourselves in a period at the end of these big policy experiments where the legislation changes again. Things are rolled back, things are underfunded, things are repealed, things just sort of, you know, policies that are on the books just stop being implemented, right? And so we keep careful track of what those policy changes were. Then again, we use whatever material we can get our hands on to document the reversal in the distribution of the social determinants of health that we expect to see when these policies are rolled back, right? So essentially growing social inequality as a result of these policy rollbacks. And then again, documenting the changes in health that we see, which we think are very likely to be a result of this growing social inequality, i.e. growing health inequalities. Okay, so we have this waxing narrative and the waning narrative. They're built on very careful and thorough and systematic literature reviews. But we don't want our audience to see any of that like undercarriage. We just want them to see the nice, appealing, shiny car on top. To draw conclusions from these case studies, we are leveraging both the cross-case differences and similarities that we see, sort of comparative case study design, but also within case, essentially waxing and waning periods before and after. This is sort of the most basic social scientific methods that you would teach like an intro level social science class, right? How do we make sense of the world? How do we know that what we're seeing is kind of plausibly causally related to something else? We look at the necessary and sufficient conditions for policy change across these four cases. Why did this happen, right? We need to understand what are the politics behind these policy changes. But we don't worry so much about external validity, right? We're looking at these four cases. They're fairly different. That's kind of good enough for us, right? We're not trying to make an argument about the whole world. We're just trying to make an argument that it's possible to reduce health inequalities and that we've shown you that it has happened in these four cases. All right, so example, US during the Great Society. This picture here, which is a little dark, is Lyndon B. Johnson, who's signing the Civil Rights Act in 1964. 1964 is really when things kicked off. The Great Society was a very large package of reforms. It was the largest expansion of the US welfare state since the New Deal. But it also, in addition to having a lot of social policy interventions that were designed to create a more racially and economically equal society, there were a lot of political changes as well. So the Civil Rights Act was an act that outlawed forms of outright racial discrimination that were very common in the southern parts of the US, that kept people from voting, that kept people from participating both politically and economically, kept people from joining unions, et cetera. So you may be asking yourself, how on earth did this happen in the United States? just by way of background, it happened because we had a Democratic president, very large majorities in both houses of the legislature, and it was a moment, 1963, 1964, when it all started, was a moment when the civil rights movement for blacks in the US was really getting started, and whites were very sympathetic to it. There was not yet a lot of the kind of thing that later prompted racial backlash in the US. There weren't urban protests that turned violent. There wasn't a lot of direct action. It was really this sort of, peaceful marching in the street that most people saw at that point, and that made most white Americans fairly sympathetic. So this is one of the largest social policy explosions ever to happen in the United States. It's also probably the largest and most thoroughly documented of our 4 case studies. There were a lot of policies that were introduced or changed during that time period. There's a massive both primary and secondary literature around those policies, and there have been a lot of attempts to uncover whether there were causal effects of these policy changes. So I definitely had the easiest job of the 3 of us in working on the Great Society rather than some of these other more less well-documented cases. Okay, so we've got our before period. What did things look like? And I'm going to walk you through this fairly quickly. It's quite intuitive. Just a few examples. Infant mortality was much higher in poor counties than it was in richer counties. This is exactly what we would expect. Infant mortality was also much higher for infants of black mothers than it was for infants of white mothers. This wasn't just a problem of infant mortality. This also had effects across the lifespan. Life expectancy was significantly higher for both non-white men and non-white women than it was for white men and white women. What do we do first? We go for our known we go back to our theories to talk about the determinants of health that we think are very likely to be at play here. And these are very well established, both in the health economics literature. Angus Deaton is a Nobel Prize winning economist who's written about this. Also in the social epidemiology literature, there are numerous textbooks that you can turn to that chapter by chapter talk about housing, education, nutrition, access to health care as some of the main social determinants of health, economic determinants of health, including employment, having a job, working conditions, income, kinds of assets that you hold, and also political determinants of health, political participation, representation, both by unions and by political parties and within legislatures. So these are very well established. And we look at some of these distributions of the main determinants of health by race and by socioeconomic position before the Great Society. Again, like a string of examples. It's really obvious. The US is a very racially and economically divided society before the Great Society programs. That's why they introduced them, right? So we can go through, a lot of this stuff came from the 1960 census. One of the things that most struck me was 31% of black families, households headed by a black household head, didn't have a toilet, didn't have basic sanitation facilities in their house in 1960, whereas only 12% of white families. 40% of non-white people were completing secondary school, 70% of whites, right? And you can go down the list and see just how unequal society was, all the way down to political participation. So in southern states where people made it very difficult for blacks to register to vote, At the state level, there was a range of 5 to 37% of eligible black voters were in fact registered, right? So in most of the South, less than a third of the population who was technically and legally eligible to vote was actually registered. And this was because of practices that made it impossible for black people to register. Great Society comes along. Oh my goodness, right? So the list of policies was very, very long. This is just a sample, right? This is a subset of the things that happened during the Great Society. Some very direct legislation that affected income and working conditions, including amending the Fair Labor Standards Act in a way that essentially brought black workers, many of whom had worked in sectors of the economy that were previously excluded from labor regulation, who brought them under the regulatory umbrella of the US state. So everything from this kind of thing, income tax changes that were very beneficial for lower income people, through nutrition, housing, education, employment programs, healthcare, and all the way down to political participation. One of the slogans of the Great Society was maximum feasible participation of the poor. And the idea here is that not only was the Great Society going to introduce programs that should make people's lives better, but that the people whose lives were affected should be given the maximum amount of participation in the formulation and implementation of the actual programs themselves. So this was a real political change in terms of political and civic participation, as well as a real change to the welfare state. So what happened as a result? We're now on step 4. Well, the welfare state obviously gets a lot bigger and a lot more protective in the US. And unsurprisingly, as a result, we see, poverty and hunger declining, and declining much more steeply for blacks than for whites, and an equalization of access to things like education and healthcare. We see this extension of labor and civil rights laws, which leads to gains in income, gains in social rights, and gains in workplace protections, particularly for non-white and female workers. And the Civil Rights and Voting Rights Act, these community action and legal service programs that were aiming for maximum feasible participation of the poor, lead to real enforceable voting rights for not only blacks, but also for indigenous Americans who gain the right to vote, and also for a greatly increased civic participation and representation for non-whites, particularly in big northern cities. And this is going to come back, so don't forget that. All right, so did the Great Society reduce health inequalities? This is our killer chart. So the non-white population is these solid lines, and the white population is the dashed lines, and they're ordered by income quintile. And essentially what you see is that for everyone, from 1960 to 2000, premature mortality is going down, which is great. It's going down a lot faster between 1960 and the mid-1970s for non-whites than it is for whites. So this is, sort of lends credence to the idea that the Great Society maybe did something that reduced health inequalities between whites and non-whites. And also, it tends to increase slightly faster in the lowest income counties than in the highest income counties. So what we think we're seeing here is a reduction in health inequalities by both race and class during exactly the period when you would expect through the Great Society and 1974 is the start of the waning period. It's when things start to get rolled back. Well, fine, you know, that's a nice killer chart, right? But do we believe it as social scientists? Maybe not, right? It is very hard to estimate causal effects when you have these big bang moments of policy change. There's a ton of stuff happening at once. There are very often not control groups. If you have universal programs or programs where there's not mandatory enrollment, it's very hard to figure out who your control group ought to be and who your treated group is. Moreover, if you want to know whether a program works kind of as a policy, you probably want to observe it when it is fully funded and fully implemented. But things aren't always fully funded and fully implemented. So you might observe a sort of pale shadow of a policy and conclude that the policy doesn't work, when in fact, if the policy had been done well, it could have produced more magnificent effects. So, you know, for all of these reasons, it's really hard to estimate causal effects. Nevertheless, because this was such a big policy change, it was very often difficult for state-level governments who were responsible for doing a lot of this to do it all at once. And so there was very often delayed introduction, state by state or even county by county. Also, certain population groups were sort of included and then other population groups included. So we sort of have a variety of clever ways to get some causal inference. And we looked for every program to see if there was any literature that showed a causal effect. And then if there was more than one article on it, did the literature consistently show a causal effect? Or was it just like somebody got lucky and found a one-off thing? These are the programs for which we were able to find in the secondary literature what we considered to be a robust causal effect. Child nutrition programs, this is essentially school feeding programs and an extension of food stamps. The Fair Labor Standards Act, Medicaid, which was a health insurance program for low-income people, including low-income seniors. Community health centers, and this picture over here is a picture of 3 women working at the first rural community health center in Mississippi. And what's interesting about community health centers is, like many of these programs, they employed people as well as providing the services that you know, whatever the program was that was supposed to provide. So there were employment effects of community health centers as well as health effects. Civil rights and the Voting Rights Act. These were the policies for which we found something that looks like, in the literature, a causally identified effect. All right, the Great Society sadly doesn't last forever. It wanes. This is very hard to read. So this is the administration, LBJ, with a tarted up Vietnam War on one arm and a very shabby looking US urban needs on the other arm. And the title says, there's money enough to support both of you. Now, doesn't that make you feel better? Problem is, there wasn't. So the waning of the Great Society is due partly to these Vietnam War-related fiscal constraints, which were real. It was also based on racial backlash. Remember I said how most white people in the US were fine with the early civil rights movement? Well, they were, until you started getting maximum feasible participation, and Jill Quadagno tells this story beautifully in her book, The Color of Welfare, and Black people started gaining political skills and expertise and running for office in urban centers. and started using these programs and distributing benefits to their communities. And Northern whites became a lot more skeptical about the civil rights movement after that. Then by the late 60s, we're also starting to see some what were characterized as riots, disturbances, mainly in northern urban centers that were met with really strong police violence. Finally, as we move forward in time, we get the first OPEC oil shock in 1973 and the rise of a neoliberal policy approach under Reagan, which is the final nail in the coffin for the Great Society. What happens as a result? This is the official US poverty rate. So we see this really steep decline in poverty through the mid-1970s, and then it kind of levels off until we get to the 2000s and it gets a little bit better again. Just as an example of one of our key social determinants of health, right? The reduction in health inequalities, again, slows after the mid-1970s as well. So the lessons that we draw from the Great Society case are, first, you can act without an evidence base. One of the most interesting things that I learned from writing this case study was that the US only started collecting statistics on poverty and on nutrition in 1963. There was no evidence base. They had labor statistics. So they knew who was employed and unemployed and in what sectors. And they had housing statistics from the census. So they knew, and educational completion as well from the census. But they had no idea what household incomes looked like, and they had no idea about the nutritional standards. And this was really remarkable because they decided to go ahead and do this stuff anyway. To their credit, they said, we better start collecting some of these statistics so that we know. There's a reason all of our charts actually start in either with the 1960 census data or in 1963 or 65, because that's when they started collecting data on some of this stuff, including health also. A second lesson that we draw from the Great Society case is go big or go home, right? Yes, it makes our life as social scientists much more complicated if we have to try to figure out what's happening as a result of the million things happening at once. But the fact is, you often don't know with policy changes what's going to work and what's not. And so if you really want to make a difference, do lots of things, right? Do lots of things at once. Throw everything at the wall and hope that something sticks. Furthermore, when you do a lot of things at once, policies can interact and amplify each other in unexpected ways, leading to even greater benefits than you might have expected. And that certainly seemed to be the case with the Great Society. A third lesson that we draw from this case is that the political reforms are really critical, and they help to sustain the other policy changes. So the waning period of the Great Society would have happened much earlier had there not been political action among the beneficiaries to defend these programs. But all is not well. Old social divisions, racial divisions for sure in the US, can come back in the form of racial backlash, but also in the form of policies that are subtly discriminatory against race in ways that somehow manage to get around the Civil Rights Act, for example. All right, so these are just sort of the lessons we draw from this one case. It turns out that these lessons are actually pretty common across all four of the cases we looked at. So in all four of the cases, from the US to Brazil to Germany to the UK, we saw that during the waxing period, the things that seemed to have the most impact on reducing health inequalities were welfare state expansion, improved access to health care, although in the US case that was a more limited result, reducing income inequality, above and beyond reducing poverty, Reducing income inequality seems to help, and that's partly because it goes along with enhanced democratic political participation. So these are sort of the four big moves that these governments all made during this period. During the waning periods, we see the opposite, right? We see the social safety nets fraying, we see social and economic inequalities widening, limitations in access to health care, and political alienation and labor repression. I really want to emphasize here that political inclusion seems to be the master key. If you didn't do the political inclusion, I don't think these other things would have nearly the effect that they have on health. This is just a quote from the end of the book. The effects on health inequalities of the waxing of democratic inclusion have been nothing short of transformational. The waning of democracy should concern us, not only because it's likely to contribute to the waning of the other three levelers, but also because it imposes new health threats, ranging from police violence to a rising likelihood of civil and international conflicts. So a lack of democracy not only prevents good things from happening, but it can also introduce a lot of things that are really bad for people's health, like, you know, getting shot by the police. All right. How did we dare to face the public? The first thing that was key is we had to decide who our audience was. And we decided based on who we knew the readership of our previous book, The Unequal Pandemic, was. This had been very popular as a teaching tool, particularly in people teaching about public health and social policy. So we geared this book mainly towards students of health policy and mainly in the UK, because it's a UK press and that's where it got the most marketing and that's who ended up reading it. So these are not experts, but they're also not total lay people. And this is helpful for us because it means that we don't have to explain every single technical term. We can assume that our audience knows what life expectancy is and why it's different at age 0 from at age 5. We can assume that our audience understands what infant mortality is, right? We do have to explain concepts that come from outside of health policy. So things like welfare regimes and political determinants, you know, that's relatively new in the social epidemiology literature, so explaining thoroughly what that means. But once we decided who our intended audience was, it was much easier to write for them, right? You're writing for your students. The second piece for us was really being very secure in our methods. And I gave you a very lengthy kind of discussion of what is ultimately just a literature review, right? To show you how we generated in ourselves confidence that we weren't missing anything, we weren't making anything up, we weren't cherry picking, that we were really just telling the story to the best of our ability based on the information that was out there and all of the information that was out there. And as a result of having this very structured way of doing our literature review, it gave us confidence. It gave us the ability to write directly and from the heart rather than kind of hedging and citing and using very specialized terms so that we are saying only exactly what we mean, right? Like all of these habits that we develop as academic writers, we write really defensively. And nobody wants to read that shit, right? So once you convince yourself by having, or for us, this was what really did it, convincing ourselves that our methods were sound and that even if we kind of loosened up a little, we weren't going to say anything wrong, that was very freeing. Thirdly, tell stories, right? People love stories. Humans are story-loving beings. One of the things that we heard from our readership in the previous book was that they loved the qualitative evidence that we showed. There's a lot of sort of dry quantitative stuff in this, And to the best of our ability, and Kat was our specialist here, she just sought out beautiful, words coming from the mouths of people who were living at that time to really kind of situate what we were talking about. So I think including qualitative evidence and original voices really helps to tell that story. And also not obsessing about causal inference, right? Like, we obsessed about it, but not in the text, right? We got all that obsessing out of the way beforehand, and then we just wrote. Finally, we kept it short. This is 130 pages. It's a slim little book with big print. You don't have to say that much. You saw how much work went into this, right? It was a huge amount of work. We all had great research assistants helping us do these literature reviews, right? It was a huge amount of work. But it doesn't all have to be on the page. So why would you want to do this? You don't have to, right? By and large, you're not even really going to be rewarded for it professionally, so you might not want to. But it can have an impact. So the unequal pandemic, we don't have great impact measures. We don't really know. We tried to find out, actually, whether it was used in any of the sort of post-COVID policy analyses. Claire was on the UK COVID Commission, and so obviously a lot of the work that she did that went into that book also went into her testimony. But, just as a very kind of preliminary look at this, since 2021, we have more than 300 citations on Google Scholar. And we won a Best Book Award from the Social Policy Association. So the book was appreciated by academics, but also by non-academics, right? It was rated as one of the best books on the COVID pandemic by the New Statesman in 2021. Many good books came out after 2021, so, who knows? But these are just indications that, people were reading it, and it did seem to have some kind of an impact, and we hope that the same will be true for this book. The other reason to do this, I think, is that it really stretches your brain in ways that feel good, right? Our brains are so, crunched in our skulls, and we're so uptight about the research that we do. And just letting it breathe, giving yourself permission to write like you actually care, and, writing what's essential and not the sort of defensive stuff that we normally write. I have found that it has had a beneficial impact not only on this work, but also on the other work that I do. So I just want to close with thanks to my absolutely fabulous co-authors. We love working together. We will probably do this again. My research assistant on the US case was Deborah Lederman, who I predict has a very, very bright career in health economics ahead of her, and Penn School of Arts and Sciences, which generously gave me a semester off of teaching to actually write the thing. Here's the kicker. Here's the timeline. So in December of 2022, we started talking with each other about writing a new book. Claire took a little while to convince me, but she got me there. By January, we had submitted a book proposal to Policy Press, which is an imprint of Bristol University Press. They published The Unequal Pandemic and have also published a lot of Kat and Claire's work. And we were eager to work with them again because we had had good experiences. Fast forward to October, and we had a contract from the press, and we're like, what is going on here? Why is this taking so long? Well, it turns out that academic presses, like every other part of British academia, are just crumbling right now. So if you look at this timeline, what you see is that It took us considerably less than a year to write the manuscript, but everything else just took a really, really long time. And so I do worry about some of these imprints like Policy Press, which make it possible for academics to do this kind of work. If they're going to move this slowly, it's going to be problematic for us to do this kind of stuff. So that's kind of like my sobering note is I don't really know where this is going. Hopefully in other countries there are other presses that can move things along a little more expeditiously. But I will close there. I have no idea how long I took. I'm sorry.